So let me clarify in next 10 to 12 minutes how to go ahead as far as these patients are concerned. So let me talk about a case. Mr. Gentleman, 64 years, an educated person, diabetes, hypertension for 10 years, past history of anti-OL MI for which he underwent angioplasty and stenting, ejection fraction 35, NYHA class 1, very stable hemodynamics, extremely compliant to treatment with good control of blood pressure and diabetes. He has CKD, previously creatinine was 1.8 and now in your clinic office when he has come it's 2.9. eGFR is 35 ml. Potassium has always remained good in your follow-up and today it is 4.8 milliequivalent. Patient is on good dose of beta blockers, Remipil 10 milligrams, statin, aspirin, etc. His GP has warned him thrice to stop Remipil to avoid further kidney deterioration and need of dialysis. He is quite confused and he says, Doctor, I rely on your decision what to do. So before we go ahead, let me understand the perspective of you all. I stop RAAS blocker once serum creatinine is, and keep your answer pads ready. Your time starts now. Can we have timer? So the number which says that I do not stop whatever serum creatinine level is, just check with yourself, are you really doing that or not? I am yet to see a physician who continues RAAS blockade beyond 2.5 creatinine in my practice, rarely few prescriptions. But check yourself whether you are doing really or not or that. RAAS inhibitors are recommended to improve outcomes in patients with CKD and cardiovascular disease. Across the world, you look at all guidelines on CKD, heart failure, hypertension, and diabetes, they all say only one thing. Once a patient has got CKD with any association comorbidity, you have to continue RAAS blockade, and there is huge amount of data available on this earth to suggest that if you give RAAS inhibitions to these people, they live longer, their cardiac mortality, the risk of MI and stroke reduces. Not only that, their further reduction in eGFR and the risk of going to end-stage renal disease and the risk of need of dialysis, they all drop down. So these are all guidelines. And we all know that, and if you attended the first lecture of today where CKD is considered a very high risk status as far as atherosclerosis and cardiovascular disease is concerned. So basically CKD is a state of accelerated atherosclerosis with very high cardiovascular and renal events and mortality. And this population is ever expanding. You will see more and more patients of heart failure and CKD because of the more longevity of life and because of increased incidence of atherosclerotic disease. Now, all these trials which are done in patients of CKD, unfortunately, most of the trials excluded patients who had either eGFR less than 45 or 30, or their potassium was 5.2, or when creatinine was more than 2.5 milligrams. So if you ask me what is a strong, relevant trial taking 5,000 people with creatinine more than 2.5 or eGFR less than 30, use of RAAS inhibitions, it doesn't exist on this earth. So if you look even to any other trial, the number of people who had CKD were just 5 to 10%, and these were soft CKDs. They were stage 1, stage 2, or at max stage 3A. Mostly, there were hardly any patients of eGFR less than 45 or creatinine more than 2.5. And that's why we are not using RAAS inhibitions in this patient. And we have certain fears in mind. Let me study what are the perceived fears we as clinicians have when we use this RAAS blockade. So I stop RAAS blocker after serum creatinine is 2.5 milligram or eGFR is less than 45 due to risk of. Keep your answer pads ready, read the answers, and your time starts now. Timer, please. So hyperkalemia is the most threatening event, and that is very right. There are people who suspect hypotension and acute kidney injury, which is quite there. And there are people who doubt that do the benefits exist after creatinine is 2.5 or not. So there is a big knowledge gap as far as use of RAAS inhibitions in CKD is concerned. Number one, we have doubt because there is no data on this earth very strong and robust to suggest that if you continue using RAAS inhibitors in people after this level of creatinine, do they really help in cardiovascular event reduction? The second question is, do they prevent further deterioration of kidney function after this level? And then, yes, safety is a serious concern because many people will have hyperkalemia, somebody would have hypotension, and somebody would have acute kidney injury. You know that there are so many elderly people with heart failure whose creatinine is 1.92. You are continuing RAAS inhibition with a good hope. And these people with acute febrile febrile illness, dengue, malaria, or dehydration end up to your clinic with creatinine of 3.5, potassium of 6. So that's a real threat. So what is the way out? So there are two schools of thought, and they both are having risk versus benefits. So there are people like me who believe that RAS blockade should be continued cautiously, because we believe that CV prevention by RAS blockade will be offered even if whatever level of creatinine is, and whatever level of creatinine is, they do reduce further reduction in your EGFR, and that's why they reduce the risk of need of dialysis. On the other side, there are people who believe that people who are having EGFR of 30, when you remove RAS blockade, their EGFR increases by 5 to 10 milliliter. And that's very important. So EGFR of 30 going to 38 or 40 is wonderful, and that's why they believe that these people will now have more time to go for dialysis, because dialysis is the worst endpoint. There are people who have risk of hyperkalemia, and as I talked to you, there is risk of hypotension and acute kidney injury. So before we go to sort of conclusions, let me give you 3 important informations based on data. Number 1, people with kidney disease, with or without diabetes, their risk of death, cardiovascular events and cardiovascular death is much more than the risk of end-stage renal disease and need of dialysis. So what I mean to say that in this people population, preventing cardiovascular deaths seems to be more important than preventing end-stage renal disease development. Number 2, which is proven on data, a patient of heart failure, when you withdraw the treatment of heart failure, particularly RAS blockade, they deteriorate, their ejection fraction goes down, their NYHA class deteriorates, and their quality of life deteriorates. So another important point is stopping RAS inhibitors is not good from CV perspective. When you stop that, it leads to problem. Third important information is people who have hyperkalemia, more than 5 milliequivalent per liter, their risk of death is more as compared to people who have got potassium between 4 to 5. And if you look to patients with diabetes or patients with diabetes and CKD and heart failure, look at here. Once the potassium has exceeded more than 5, the risk of death increasing very steeply. So another important point is hyperkalemia must be avoided. So keeping all these 3 important points in mind, how to go ahead as far as RAS blockade is concerned in patients with CKD, with or without hypertension, with or without heart failure, with or without diabetes. Number 1, define which are the patients who have got high risk of hyperkalemia. Number 1, those who have got high baseline creatinine, dehydrated people, people with heart failure, and people with renal artery stenosis. So every patient of CKD where you want to give RAS blockade, you have to rule out renal artery stenosis. And there are certain medications which can lead to hyperkalemia, which you know, spironolactone, triamterene, NSAID, etc. You have to suggest them low potassium diet. It's a problem. How to reduce your potassium intake in food? You have to cut down on fruits, which is not good. There are people who use Sindhalune, and Sindhalune in CKD patients should be avoided because that's where potassium is more. There are nephrologists who give Sobis, sodium bicarbonate, as a supplement to prevent hyperkalemia, but then in patients with heart failure and hypertension, it may worsen the cardiac status. You can use diuretic very judiciously, because if you over-dehydrate the patient, the risk of hyperkalemia is more. And using a little touch of thiazide type of diuretics or loop diuretics can help to reduce potassium. Regular assessment of renal function and EGFR and potassium is extremely must. Either a patient who is not ready to undergo regular assessment, or a doctor who is not ready to ask a patient to undergo repeated assessment of, or if there is no good laboratory facility available, that's where you cannot use RAS inhibitor in people with CKD. It's very, very important. And a doctor has to be dynamic in the sense that when patient is on RAS blockade with creatinine of 2, now he or she comes with dengue or malaria or some fever with creatinine of 3, at that time you might have to hold, let the patient go back to normalcy, and then you have to restart in a small dose. That's how you have to be a little dynamic. Using lower dose of RAS inhibitors doesn't serve the purpose, but very important point that mineralocorticoid receptor antagonists should be avoided once EGFR is less than 30, or potassium is more than 5.5, or creatinine is more than 2.5. Another new thing which is on horizon is using K-binding agents on long term. What we are using in our clinical practice as K-bind is SPS, sodium polystyrene sulfonate. That's something which is dangerous and not tested for long term. There are 2 other potassium binding agents, petiromar and sodium zirconium citrosilicate. These 2 are on horizons, and both of them, tests have been done, trials have been done for up to 1 year. In people with CKD who are on RAS inhibitors, when their potassium is more than 5.5, you continue RAS blockers, add on these potassium binding agents, that is particularly petiromar, for 1 year, and these are the people, most of them will not go for hyperkalemia. This is relatively safe agent, and that's where 2-3 trials are already out. I personally believe that future is awaiting some such agent which can be combined with the RAS blockade so that you can give RAS blockade comfortably to people with CKD. Now, what about monitoring? It's very, very important. If you are not ready, or if your patient is not ready to monitor, then there is no role of RAAS inhibitors. So you have to define patients whom you give RAAS blockers in CKD. Either they are low risk or high risk. Who are the low risk people? Whose baseline blood pressure is good, whose baseline eGFR is good, that's mean they are in stage 1 or 2 CKD, whose serum potassium level is normal and quite low, and whose drop in GFR, once you start inhibition, is less than 15%. Because whenever you start RAAS inhibitions, the GFR is going to drop. You have to assess what is the drop in the GFR. If it is less than 15%, then these are low-risk patients. That's where every 2 to 3 months renal function test is needed. While there are people who are high risk, their systolic BP is low, their eGFR to begin with is low, their potassium is on the borderline, and when you start RAAS blocker to them, their drop in eGFR is more than 30%. These are very high-risk patients, and that's where you need to repeat RFT maybe 1 week or 2 weeks or even less than that time. So this is an extremely important point. So carry home message for my ordeal clinicians and friends. More research is needed. One such trial is going, which is called a STOP ACI. These are the CKD patients. Once they cross creatinine of 2.5, they are randomized into 2 groups. One is you stop RAAS inhibitions and follow them, and this other group is continue RAAS inhibitions and follow them. This trial will answer us whether we have to stop or withdraw RAAS inhibitions or not. Looking to available data, I personally believe that we need to continue RAAS inhibitions in CKD in most of the patients. Yes, check the risk factors for hyperkalemia and be careful about monitoring. No spironolactone or eplerenone once the creatinine is more than 2.5. And regular use of anti-hyperkalemic drugs, that is petiramol-like, are on the horizons. I personally believe that this lecture should promote you to use RAAS inhibitions with careful approach in most of the patients with CKD. Thank you very much for your kind attention.